Hello, everyone. Nice to see you, to speak with you. We can go to the next slide. So I'm with Partners in Care Foundation. So our mission is to align the social care and healthcare to address the social determinants of health and equity disparities affecting diverse, underserved, and vulnerable populations. So we've been around for 25 years now, and we've grown quite significantly over the past, 5 to 10 years. And we do a lot of this. So next slide. So a little bit about creating some partnerships with payers. So historically, we've reached out to payers offering our services. Over time, they've started to come to us requesting specific services because we've built up a reputation. Opportunity arose and we seized it and we built around it. So a big thing is identify the need. So what is the market need? I think all of us here are at least at that point. We know there's a need for care transitions, right? The hospitals recognize it, we recognize it. So this is what the market is looking for. So next, there's some organizational considerations, right? So do you have the bandwidth to do these programs? Do you have enough staff? Do those staff have time? Do they have the knowledge? Is it sustainable? So do we have a long-term source of revenue for this program? Is it a short grant? Yes, there's viable codes. Is it sustainable? Is this something we want to put our time and money into because it's going to last? Mission and vision alignment. Does it align with your mission, right? Is it something your organization wants to go into? Does it align with your values? Is it something that is going to continue with the vision of your organization? And then infrastructure. So the infrastructure, kind of goes along with the bandwidth, but do you have systems available? Are there IT systems? Do you have billing people who can handle this? Are there people who can help you set up the reporting? Do you have all of that available? I'm gonna get a next slide. A little bit more on things we consider. We do a lot of research, right? So we assess prospective healthcare providers' service needs. So how we do that, we look at a lot of data on like Medicare readmissions, who is struggling the most with it. We show up at a lot of specific health conferences and to start building relationships. If possible, we try to present and be on those panels. We go to a lot of conferences to build relationships. We look at data from the US Census, environmental and policy monitoring. So what kind of policy and benefit changes are happening? Like these new Z codes, new billing opportunities, what opportunities are there? We keep relationships with other state organizations, state Medicaid, all those other ones. We look at the new money. Are there new grants? Are there new federal policies, state policies? Are there new policies coming out that hospitals have to do these things now, like the new SDOH screenings? These are all opportunities for you to kind of get in there. Like there's a new need, new opportunities. So start developing those relationships so you can get in there and be a part of that. And then after you do all your research, you determine, yes, you can handle this. Try to do a pilot. So when we started with our transitions program, it was part of the Community-Based Care Transitions Program Demonstration Project, or CCTP, and that came out of CMS under the Affordable Care Act. So we worked with 3 communities over 3 years to reduce average 30-day readmission rates. They were averaging 20.6 before us, and then after that pilot, it went down to 13.9%. So as a result of that pilot, we were able to continue with some of those hospitals and build our current program. And then from there, we continue to grow it. But the pilots usually show, yes, we can do this, we can be successful at this, and it's worthwhile to keep us. We can go to next slide. So how to grow those contracts to scale. Referral minimums. If at all possible, we try to build referral minimums into our contracts to guarantee that you have to give us at least this number of referrals. Because if you're not getting referrals, you're not going to be successful, right? If there's nobody to serve, you can't show that you're successful at helping people. Active versus passive referral process. So if it's an active one person at the hospital, two people at the hospital are in charge of referring you patients, it's a lot riskier, right? If something happens to those people, they move on to different jobs, they're out sick, your program might just go away. Nobody knows about it. If it's an automatic referral process, hey, everybody who is this category automatically gets referred to you. It's a lot safer. It's a lot more dependable because it doesn't rely on humans. And then workflow is critical. You have to co-design the workflow with your customer, your payer, to make sure everybody is really, really clear on those expectations, what data is being shared, how communications happen. You have to write it out and agree to it, put it in your scope of work, your contract. Don't just assume. I know a lot with hospitals that we work with, they assume, oh, you're going into their home. Of course, you're monitoring vitals, you're checking, wounds, you're doing all this. And I say, no, 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 we're not clinical. We're coaches, we're social workers, we're case managers. We're just doing the SDOH stuff. So make sure that everybody's super, super clear on what it is that you're actually doing. And especially those data points. Sometimes people, I assume, oh, of course, we're going to just give you these certain data points. And then the hospital starts asking for all these other things that we weren't collecting, we didn't realize would be important. So try to get all of that in there as much as possible. Some of the considerations that you want to make sure you put in your workflow also in co-design is the financial viability. As I mentioned a little bit before, but what are you getting paid and what does it actually cost you to do the service? We do a lot of time studies with our own internal staff. What does an easy case, how long does that take start to finish? If somebody has a lot of needs, how long does that take start to finish? What is kind of an average there, plus IT, plus, oversight, supervision, all of that. Are we actually getting enough to cover what we need to pay? Staffing viability. Do I have enough staff to actually do this? Are they busy with other things? Is everybody leaving? Are you having trouble hiring? Is this a good time? You want to make sure you take that into consideration. Volume, again, those referral minimums. We've in the past have had partners, give us 10 referrals every week consistently and then say, hey, I have 400. Can you take that tomorrow? No. It takes a little while to staff up. You can't just go from 10 to 400. So make sure that everybody's on the same page there. And then, after your pilot, you've been going for a while, try to show proof of your services. So, look to publish, look to validate your concepts, take all that data and show where you were to start and where you ended up. Next slide. Yeah, okay. Some more implementation tips. So have a dedicated, identified individual who's responsible for managing the rollout and the operations, who understands the scope and the stakeholders and everything going on. Sometimes it's this person and then also this person and then this person a little bit, and nobody is in clear of like who's actually taking responsibility. So make sure you have one person at least who is like very much, this is the responsible person. So if things come up, what is happening. Historically, we've kind of used sweat equity, like who do we already have around that can take this on? But now we do ask for startup funds. Hey, can you give us some money to make sure we have this oversight built in? The IT system. So ideally, you would have some sort of system in place that manages referrals. Your case management can deal with reporting and billing. For a lot of our programs, when we started off, we used Excel tracking. We would make people fill out their Excel sheets every day, and then we would compile them. We would use PDFs and Word for our documentation. And it's a little bit messy. It's a little bit more difficult, but it's possible, right? You can do that. Then we moved to an outside care management company that we contracted with, and we did that for many years. And now we're building our own internal case management software, so we can keep everything in house, so we can manage all these contracts. But make sure you have some way to track and keep track of that data. Building a relationship for the with your provider or your payer. Um, that relationship is so important, and that's how you're going to continue to grow and build your programs. So stay on their radar. Make sure you have regular check-ins. You don't want them to forget about you. Have weekly. To start off with, we meet weekly or biweekly, and then we move to like monthly, sometimes quarterly, depending on the programs. Make sure you stay meeting, and everybody is aware of what's happening. If you're working with a hospital, like the transitions programs, make sure the hospital knows who you are too. We like to do a lot of FaceTime. We'll go into the hospital, we'll join their team meetings. We have flyers. We want to make sure that when they see us in the hospital, they think, oh, look, there's Rebecca. Let me make sure I refer my patients to her. That you're built in, you're part of the flow, so you don't get lost. Supervision. Um, Especially when you're first starting out, you really have to be on top of your team, right? You have to be fast, you have to communicate well, and you have to get a result. And that's beyond just getting the contract. In the early days, your team needs to stay really flexible, adapt to changes. No matter how well you plan things out, unanticipated challenges are going to come up, right? Things are going to come up, things you didn't anticipate. You have to make sure you're really working closely with your team, and you guys are really flexible and on top of that. Next slide. So some of our plans for the future. We are working on these new billing codes. Like most of you, we are still struggling to find those implementation. We have this existing program, and we are hoping to grow it with these new billing codes. We are working with our partners, with our hospitals, to try to see how we can make that work. But we are still in those discussion stages. We're also expanding to some Medicare Advantage programs. So we're looking, we have a partnership with an IT company that we're looking to expand there. Again, we're still a little bit further along in the talks for that. So hopefully that is not as far out. And then we're looking just to continue to grow a lot of our current service lines. The transitions work is really popular right now. Hospitals are learning about it, and they see how valuable it really is to their patients, to their readmissions. So we are looking to continue to grow that as well. I think that's the last slide there. I know I speak too quickly when I present, but there are some questions, right?
Yeah, thanks, Rebecca. Yeah, we did get a couple questions come in, and feel free if anyone else has questions to throw them into the chat. A question about referral minimums. The question
Yeah.
came down to sort of how do health plans or hospitals perhaps respond to that, and talking about setting those minimums. Any advice on establishing that benchmark?
So in my experience, the health plans are not as big a fan of that, but we are able to get that more with the hospitals we work with. So when we start our relationships and our contracts, they are much smaller minimums, and then we show how valuable we are. We are able to give that data back to them, and to show them how good of a job we're doing. And then those minimums have continued to grow. So where they started off with just a handful, we're going to promise you 5. Now it's much larger because they've seen the value there. What kind of platform?
Mhm.
So right now we're building a Salesforce database, and case management software for our use internally. But again, we've used all sorts of things. We've used the technology of our payers. Sometimes people say, hey, we have this already, we want you to use it. We use it. We've used some other ones, Excel, which is, it works if you only have a handful of referrals. The bigger you get, the trickier Excel is. There's a lot of different platforms out there. As long as you're able to pull that data out and manipulate it works pretty well.
And a follow-up along with that is, how does the issue of patient consent fall into this process when you're setting up sort of an automated referral process?
So for our hospitals, they refer the patients to us, and the way they see it is kind of like, home health or something like that. And they refer it. Once we get the referrals, we try to see them inpatient while they're still in the hospital. And then we consent with them. We say, hey, I'm your coach. When you go back home, we're going to reach out to you. We're going to do a home visit. And mostly people are fine with that. If we can't see them inpatient, then we'll call them after they discharge. And same thing, hey, I'm your coach. We're going to set up a home visit and we're going to come out. Occasionally people will tell us, no, thank you, I'm not interested. And if they do, then they do. We just BART them. They declined. We don't, it's fine. But very rarely do people actually decline when we can get a hold of them. I think the larger problem is not being able to get a hold of them.
One issue that's come up, and I think we probably have time for one more question. One issue that has come up in previous sessions and discussions is making sure that the patients are aware of who you are and how that communication is made. What have you learned from your partnerships to help facilitate and make sure patients are fully educated on your role and your organization's role?
Yeah. So for our largest partnership, if we get the referrals early enough while they're still inpatient, we are added to their discharge paperwork. So along with their future appointments, home health, it says partners in care, care transitions. So they know, oh, we're official, right? We're from the hospital. We're not just some random people calling them. And so they can see our information. It's right there. And that helps a lot with that stranger danger, to learn who we are. And then again, when we go see them in the hospital, we leave them brochures. Hey, just so you remember, we're partners in care. We're going to call you as soon as you get home. And then when we call them too, we say, I'm calling on behalf of the hospital. We're calling on behalf of St. Joseph, and so we brand ourselves with the hospital. So again, it's not scary because they get a lot of calls, right? And especially older adults, it can be kind of scary. Who are you? Why are you asking me all these questions? So as much as possible, we do align ourselves with the hospital and add ourselves to that discharge paperwork so that they know. Some of our hospitals, the nurses and staff are really good about introducing us also, and some of them not as much because there's a lot of turnover and they're busy, right? They have a lot of stuff going on, so it's harder for them to remember us.
Thank you, Rebecca. I did see another question come in. I do want to move us along to our next presentation, but if you have questions, if anyone listening, if you have questions for Rebecca, you can still add them to the chat. We will follow up with Rebecca and have answers to those questions supplied and posted on the TA community site.